Ahoy there, matey! We're on the high seas for this sketch. A lot could be lurking in these waters, so let's hope this merchant ship has steady wind and smooth sailing. Take a deep breath because we're about to chart a course through the lungs. Let these glorious, squall tested sails represent the lungs. You'll see sails as a recurring symbol for lungs throughout Sketchy, and we made these sails extra large to remind you that the lungs occupy the majority of space in the thorax. Because we always talk about anatomy as though we're looking at the front of the patient, the right lung sail is on the left side of your screen, and the left lung sail is on the right. This will be important as we discuss differences between the left and right lungs. The apex of the lungs extend several inches above the clavicle, just like these sails extend above that top beam, and they reach all the way down to the diaphragm, the thin muscle separating the lungs from the abdominal organs. This means that neck injuries, like a stab wound at the base of the neck, and abdominal injuries have the potential to injure the lungs, along with injuries to the chest, of course. Coast ho, mateys! After months of close quarters, could it really be safe harbor? Good thing there's a trusty spotter in the crow's nest. Notice how we placed this sailor up near the apex of the lungs or sails? He's a reminder of the type of cancer that forms in the apex of the lung called a Pancoast tumor. Because the apex is near so many important structures, tumor invasion can cause a lot of damage, including to the superior cervical ganglion, causing Horner syndrome, as well as damage to the subclavian vessels, the brachial plexus, and even rib, vertebrae, and spinal cord invasion. Just like these sails are strung in front of that heart-shaped wheel, the lungs cover most of the anterior surface of the heart. A good way to remember that penetrating chest wounds will typically hit the lungs before the heart. Well, land might not be far off, but this ship seems kinda dead in the water. Let's harness some wind and follow the path air takes to reach the lungs. Here we go, a leeway gale. This cloud is more than just a breath of fresh wind. Its aptly sized nose and mouth are where the airway starts, continuing into the pharynx, then the larynx, and finally the trachea. With that face, clearly, this cloud isn't messing around. Good thing there's sturdy rigging on this old schooner. Just don't be surprised if these rope ladder rungs seem rather cartilaginous. They represent the rings of the trachea. The trachea descends from the larynx through the neck and into the chest, anterior to the esophagus, hence our little trapped goose behind the rope ladder. On CT, the trachea can actually be a helpful landmark to identify the esophagus. The trachea will be air-filled, held open by its cartilaginous rings, while the esophagus is usually collapsed with no visible lumen, posterior to the trachea and anterior to the vertebrae. The trachea branches into the right and left mainstem bronchi, which go into the right and left lungs, just like this rope ladder branches into two for access to each individual sail. The split is called the carina. The mainstem bronchi have important relationships to the pulmonary arteries, the arteries that carry blood needing oxygenation to each lung. We've outfitted this vessel with a special rail system to symbolize the pulmonary arteries, along with empty buckets the color of venous blue blood. Just a reminder that the blood in these arteries is empty of oxygen. Take a closer look at the locations of these rails. They'll help you remember that the right pulmonary artery runs anterior to the right bronchus, and the left pulmonary artery is superior to the left bronchus. The mnemonic RALS, which kind of sounds like rails, like these rail systems, ought to help this image stick. The mainstem, or primary bronchus, of each lung branches distally into secondary and then tertiary bronchi, separating the lungs into lobes and segments. Branching continues all the way down into the alveoli, where the magic of gas exchange happens. It's a good thing this ship is close to land. The sails could use some repairs. Though it turns out that the patch job done at sea is a good representation of the lobes and fissures of the lungs. The right lung has 3 lobes, upper, middle, and lower, while the left only has 2 lobes, upper and lower. The space that is taken up by the middle lobe on the right is actually taken up by the heart on the left. The left doesn't totally lose out, though, because the left upper lobe gets a little extra tongue of tissue called the lingula, like this L-shaped tongue of flappy sail as part of the upper lobe. Think in terms of all these L words. The left has less lobes and the lingula to help remember this lung lingo. The lobes are divided by fissures. There's 3 lobes on the right, so there's 2 fissures, the horizontal and oblique. The horizontal fissure separates the right upper lobe from the right middle lobe, and the oblique fissure separates the right middle lobe from the right lower lobe. There's only 2 lobes on the left, also separated by an oblique fissure. These fissures can help localize pathology on X ray, especially pulmonary consolidations, which typically represent fluid and cellular debris from infection. Usually they're indistinct, but if a consolidation is next to a fissure, which debris can't cross, there's a straight, distinct line outlining the fissure. In fact, very few diseases can cross the fissures. In the right lung, if it's above the horizontal fissure, whatever is causing the consolidation is happening in the upper lobe. Below the oblique fissure is the lower lobe, and between these fissures is the middle lobe. Same goes for the left lung. Above the fissure is the upper lobe, and below is the lower lobe. As a reminder of this concept, we've added a tasteful amount of seagull poop to the upper lobe of the sails. Oh, and note that gray gunk hasn't crossed the oblique fissure. Oh, look out! Oh, not the gull poop. This ship is square in the crosshairs of pirates. Notice how this pirate ship is attacking the right side of our merchant ship? That's because the mainstem bronchus is shorter, wider, and has a less sharp angle away from the trachea, which makes it much easier for foreign objects to travel down. For this reason, foreign objects or aspiration are much more likely to go down the right mainstem bronchus. Whew! Whoa, heads up. That cannonball, or as ENTs say, foreign object, is about to take the wind out of our sails. Foreign bodies can completely obstruct a mainstem bronchus, and without ventilation, the entire lung can collapse. These patients need prompt medical attention. Just like this sail's going to need some prompt patching if our merchant ship's ever going to make a run for that shore. Aspiration is when someone inhales food or liquids, and I don't mean just eating really fast, but literally inhaling it down the wrong pipe, leading to inflammation and infection in the lungs. This wave of water crashing over the right side of the bow is definitely not helping matters. In addition to a higher likelihood of going down the right bronchus, aspirated fluid will also go into the most dependent areas of the lung, which depends on the position the patient is in. If the patient is supine, or laying flat on their back, the aspiration is most likely to happen into the superior segments of the lower lobes, and sometimes the posterior segments of the upper lobes. So this guy, with some insane core strength hanging onto that beam, is in the superior aspect of the lower lobe. It's like the reverse plank on a plank. If the patient is upright, aspiration happens in the basilar segments of the lower lobes, just like this sailor who is upright while sliding down the rope. When lying on the right side, also called right lateral decubitus position, aspiration happens in the right upper lobe. And finally, if they're prone or lying face down, aspiration goes down into the right middle lobe, which is most anterior, and if it goes down the left bronchus a bit too, it would be into the lingula. A memorable crew, for sure. Well, that's where we'll leave this high seas tale. Let's recap before making our getaway. The lungs take up most of the thorax and cover most of the heart, extending from the lower neck to the diaphragm, and are vulnerable to injury in all these areas. The right lung has 3 lobes and 2 fissures, and the left lung has 2 lobes and 1 fissure. Remember, the left upper lobe has an extra flap called the lingula. Air enters the lungs through the airway, starting at the mouth and nose and into the trachea. The trachea splits at the carina into the left and right mainstem bronchi that go into each lung. The right is shorter, wider, and straighter, making it easier for foreign objects or fluids to enter it. Foreign objects can get stuck and collapse the lung, and fluids like food or water end up in the most dependent areas of the lungs, depending on the position of the patient. All right, let's scuttlebutt out of here. Helm's a lee, give no quarter, bilge the poop deck, batten down the jib sail, splice the main braces. Okay, I really have no idea what I'm saying anymore.